Everyone, thank you so much for having me, and thank you, Asma, for letting us discuss our problems with the panel of experts. So I will make it as brief as possible. So I will be discussing my patient who was a case of metastatic bone pain due to CA prostate. So the brief history of my patient. The patient presented to us in our pain OPD in August 2024 at Refractory Hospital in Khan, and with excruciating pain in the right side chest. And his previous history, the other history is 76-year-old male, known case of diabetes hypertension for 4 to 5 years, well controlled on oral medications. And back 2024, he got diagnosed with CA prostate after a TURP procedure, and his biopsy revealed adenocarcinoma of the prostate gland, and his lesion score was 9 out of 10. Before coming to us, he was referred to Minot, that is Cancer Hospital Ziauddin, where his MRI bone scan under test were done. So his MRI confirmed the prostatic malignancy that is extending up to the periurethral region, but no large lymph nodes and iris. And bone scan, it showed the maximum 6th and 7th step on the right side, also involving dreadful number vertebrae. And his CT test was clear and no mets in 1 month. So this is a picture of his bone scan showing the 2 metastatic lesions in the 6th and 7th rib. So this is the detail of the pain. I will cut it short. The patient had 2 types of pain. The first is spontaneous burning pain that was with the walls of 3 and 4. And then he had a lot of episodes in 1 month. That is the you can say sharp shooting pain, breakthrough pain, and that was with the walls of 8 to 10. And there was like the aggravate on breathing, palpating, coughing, lying on the side, and cough compression. It improved partially with the opioids and acids. And it was associated with anemia and hypergesia and chills. My patient was never been on steroids or gabapentinoids and bisphosphonates or antidepressants, and he has multiple episodes of breakthrough pain in 1 month. And this is his score. So before coming to us, patient was taking chemotherapy like androgen deprivation medicines, and he was also taking NSAIDs, COX inhibitors, opioids, venlafaxine, that is combination of tramadol and paracetamol, and he was also on tibentalol. Because pain was not settling with the venlafaxine, so the oncologist actually shifted into tibentalol. And then he also get IV opioids and thoracic one short epidural, thoracic epidural, that was effective for 2 weeks. So when he came to us, we added gabapentin. We also gave him local applications of capsaicin gel and xylitol, and patient was also educated how and when to take the rescue medicine. And now about we were left with only interventional options. So we gave him ESP block, the electrostatic block in August, that was good enough for 4 months, and then in December he came to us again with again excruciating pain on the right side chest, and we gave him paravertebral pain block, paravertebral space block, and still he is pain free because we have much time as well. So we took oncologist on board again, and we discussed the treatment with him. These things are not available at our setup: the morphine, fentanyl, bisphosphonate, radiofrequency, ablation, and expertise in very sophisticated procedures like we have seen here yesterday. And follow-up, we are doing it telephysically every month. Although the pain settles after the neural blockage, but it recurs. And the second thing that is very serious is recent complaint of pain radiation to the backside of the shoulder, that is scapula, and that is our main concern right now. We have gone through some investigation like X-ray of the shoulder and the scapular region, but that was of course that was fine. And right now we cannot go for bone scan because he is unable to travel. So the pain he is having in the shoulder, however, it's deep, continuous, body pain, no sensory loss, and not associated with movement, cuffing, and pressure. We were thinking about that it might be the metastasis either, or the osteoarthritis, but osteoarthritis was told us on the X-ray, or if there is no history of trauma. So we were thinking about the metastasis of the nerve impingement, maybe nerve involvement due to cancer. So our problem is that, so the main concern is, do we have to, like you can say, do all the time intervention whenever he comes to us? And the second thing is, what should we do with the shoulder pain? Because the fear of the patient was that he said to me, like, क्या जिंदगी भर मुझे सुइयां लगाते रहेंगे तो the RNA was I don't know how long we will live. So that's it.
So only single answer because we are running short in time.
Just two questions. Number one, how was the disease control? And number two, where was radiation oncologist? Do you want to radiate that area?
Yes, sir. The radiotherapy was not an option because there was multifocal lesions. So the oncologists they decided to come the chemotherapy. So patient.
No. I think I would completely agree. Single fraction radiotherapy would be one of the first options you should try. In fact, if that is already tried, then interventions have two roles. One is to buy time till the radiotherapy works. Sometimes it can take a few weeks. So you can do something like what you did to cover that. But again, this आपने जो बताया बहुत correct है. बार-बार मुझे आके सुई लगाना पड़ेगा. This is why I said you want to do one procedure that will outlive the patient if possible. And that is why I'm very particular about that. If you keep repeating, then there's another aspect. If you are to pay for the treatment, if they have a budget for oncology treatment, they don't want that budget to be eaten away by other procedures which will not do anything to the cancer. That's how patients believe. So you want to...
Right direction. It's not a right direction.
Yeah. And not only that, I mean, they are assuming that they can spend more on the cancer treatment. So this is where I said that if you, ideally you should be able to do 1%. So shoulder ke baare mein I want to ask one simple question. How is the movement at the shoulder?
That's fine.
Full range of movement.
Yeah. That's fine. Patient is not having any restriction of the movement.
Okay, which effectively means that the joint is fine, the rotator cuff is fine, and the associated muscles are fine, which means it's very likely to be a referred pain from the spine. There is full range of movement, the joint is fine, the rotator cuff is fine, the attached muscles are fine. Usually, if that is the case, it is a referred pain. Usually, not always, but usually.
So, sir, your final answer is like about the...
You need to find out where the pain is coming from. That is what I'm saying. It is not from the shoulder, isn't it? One thing I will say is, don't do guesswork. Guesswork is not a good idea. Particularly, you got to remember, these patients, we sometimes get only one chance to get it right. So try not to do guesswork. That's